thyroid glands. So now we go for parathyroid glands. I hope you can hear me and see the screen.
Yes.
Okay. So yeah, basically, you know that we have each person has around four parathyroid glands. These are small glands which are just close to they are at the back view or posterior view of the thyroid gland. Maybe that's why they're called parathyroid. So there are two pairs. There are some people who have three pairs. They also have three glands and so on. But the majority of people, they have four glands or two pairs. So they historically they have chief cells which regulate serum calcium via parathyroid hormone PTH, which I mentioned just in the morning that the function of this hormone is the opposite to that of calcitonin. Calcitonin, which is produced by parafollicular cells within the thyroid gland. So for them then to regulate the calcium in the serum, they increase the bone osteoclastic activity, releasing calcium and phosphate. As such, there will be higher concentration of calcium in the bloodstream because of if there is a high titers of PTH. Also, this hormone increases the small bowel absorption of calcium and phosphate. And this indirectly, it does it by indirectly activating vitamin D. Also, it increases the renal calcium reabsorption in the distal tubule and it decreases the phosphate reabsorption. So it is as if for the GIT and the bone tissue, this hormone increases the phosphate content in the blood. But at the urinary system level, it seems this hormone tries to decrease the concentrations of phosphate. And basically, this is because so here we have increased serum ionized calcium levels provide a negative feedback to decrease PTAH secretion. So this is one. But another thing I want to say here is that usually when there is higher phosphates, the calcium goes down. Probably that's why here, to ensure that calcium is enough in the blood saturation, PTH will also decrease phosphate through the urinary filtration. So the diseases, we have hyperparathyroidism. It can be primary or secondary. So secondary, it is when it is caused by another disease. So primary, it is when it is just due to overproduction of PTAH due to parathyroid gland itself. While the PTH is high, but this is due to other causes which are beyond the parathyroid gland. We call it secondary hyperparathyroidism. So the most common cause is the parathyroid adenoma. As I understand, it is a benign tumor arising from this gland. So, and it represents 80%, more than 80% of the cases of hyperparathyroidism. So sporadic parathyroidism hyperplasia, also it is another cause. So only hyperplasia, not adenoma. And the parathyroid carcinoma, also they are causes, but these are not frequent as the adenoma itself. So parathyroid adenoma is a benign neoplasm, usually involving one gland, not all the four glands. So while hyperplasia, usually it affects more than one gland. So most often this results in asymptomatic hypercalcemia. However, it may present with the consequences of increased PTH and hypercalcemia, And these consequences include for nephrolithiasis, meaning that there are stones composed of calcium oxalate within the kidneys, and nephrocalcinosis, which is metastatic calcification of the renal tubules, potentially leading to the renal insufficiency. And I think metastatic calcification, you saw the two types of calcification, or three. So we have what we call dystrophic, which is seen where there has been inflammation with necrosis, and this is usually localized in these areas of inflammatory changes or necrosis, or when someone is aging. So usually you find them around the large vessels, the large arteries, you find calcifications. While the metastatic calcification is due to increased calcium in the serum. So the third category of calcification, tissue calcification, is subnormal bodies that we saw even for the thyroid papillary carcinoma, papillary thyroid carcinoma. So most often, it results in asymptomatic hypercalcemia. So it means there is increased serum calcium, but without any symptoms associated with that. However, it may present with consequences of increased PTH. So this is a repetition. So we wanted to continue with other signs. So this paragraph is seen in the previous slide. So there's a signs apart from nephrolithiasis and nephrocalcinosis. Another consequence may be central nervous system disturbances such as depression and seizures, constipation, peptic ulcer disease, and acute pancreatitis. You understand this is at the level of the alimentary system, or osteitis fibrosa cystica in the bones. So you can understand osteitis, there's inflammation in the bones, and there's a fibrosis around there, and there's some cyst formation. So resorption of bone leading to fibrosis and the cystic spaces, as you can see on this picture. So laboratory findings include increased serum PTH, increased serum calcium, and decreased serum phosphate, and increased urinary, this is CAMP, adenosine monophosphate, and increased serum alkaline phosphatase. Because you know, when a bone is being destroyed, usually there is alkaline phosphate which increases in the bloodstream. So that is the meaning. So the bone will be resorbed because of the action of the PTH through osteoclast, and first the calcium will increase and also alkaline phosphate will increase. Phosphate should also increase, but you know, this PTH makes sure the phosphates, most of phosphate ions are lost through urine. So the treatment will be the surgical removal of the gland, which is affected by that mass. So the secondary hyperthyroidism, as I said, it is when we have a hyperparathyroidism, which is due to causes outside the gland itself, the parathyroid gland itself. So the causes are listed here. So there is excess production of PTH due to a disease process extrinsic to the parathyroid gland. Most common cause is chronic renal failure, and it is also shown here in this diagram. And also when someone doesn't have enough vitamin D, because this vitamin D, it is usually involved in the reabsorption of calcium, and also, I mean, at the glomerular level or nephron level, but also vitamin D helps at the absorption of calcium through the intestine absorption. So the renal insufficiency or renal failure will lead to decreased phosphate excretion. And when there is a decreased phosphate excretion, it means because there is always a kind of a balance between the calcium and the phosphate. If phosphate becomes highly concentrated in the blood, it means calcium will decrease. And this is because the increase also the increase in serum phosphate will bind the free calcium. So you take calcium around who you want, because here it is binded. Because usually they analyze it is the free calcium. So free calcium stimulates all four parathyroid, decrease in the free calcium stimulates all the four parathyroid glands. And understand, if they are stimulated, then these parathyroid glands, they will secrete, the parathyroid glands will secrete a higher PTAH, which will lead to bone resorption. You understand that this is a compensatory mechanism. They will lead to bone resorption, contribute to the renal osteodystrophy. You understand, the renal osteodystrophy, it is osteodystrophy caused by renal problems. So renal failure, because of the process we read here, then at the end, the bones will be resolved. So lab findings include increased PTH, low serum calcium, higher serum phosphate, and increased alkaline phosphatase. So I think if you can compare these things to the previous slide, the most of laboratory findings will be the same. Increased PTH, decreased serum. So in primary, we have both calcium and PTH, they are increased, and the decreased serum phosphate. So here, what they have in common is increased PTH, while the calcium here is decreased, while in primary hyperparathyroidism, it is decreased, and also the serum phosphate here is increased, while on the primary disease, it is increased. So phosphatase, alkaline phosphate is increased in both. So the difference here resides in the calcium and the serum phosphates. Phosphates. So now hypoparathyroidism, it means there is low PTH. The cause include autoimmune damage of the gland, excision. Ngira ngo ahangaha kimwe mu bibazo ukunda kubona uko iyo bakuyemo tiroyide, ko parathyroid gland kaba ari gatoya, ari umuntu utabimenyereye nawe kuramo. Tujya tubibona bagakora umuntu thyroidectomy, wareba kuri histology ugasanga harimo na parathyroid. So tuvuge rero bakuyemo parathyroid ebyiri cyangwa eshatu cyangwa enye, birumvikana ko hahitabaho ikibazo gikomeye. So DiGeorge syndrome, it is a syndrome, a genetic hereditary syndrome, or a genetic problem with absence of parathyroid glands. So the presentation, the symptoms are related to low serum calcium. Then the patient will present with numbness, tingling, muscle spasms, or tetany. Kandi ngo banafashwe n'imbwa cyagiye baba bari gukina cyane cyane, siko hariya ishobora kuba ari calcium cyangwa se iron, fer. So this spasm, tetany, may be elicited with feeling of a blood pressure cuff. Ni ukuvuga igihe uri gupima umuntu blood pressure, n'iriya cuff bashyize ku kuboko, akaba ariyo ituma agira iyi muscle spasm. In that case, it will be called a trousseau sign, or by tapping on the facial nerve. If you tap, you tap on the facial nerve, and then there is a tetany. This will be called Chvostek's sign. So laboratory, you will find the raw PTH and the raw serum calcium. And there is another thing which is called pseudo-hypoparathyroidism. So the person has the features of hypoparathyroidism, but which is not a true one. So, and this is due to end organ resistance to PTH, meaning the PTH is there, is produced, but you find that the person has signs of hypoparathyroidism. So, meaning that there is low calcium. So laboratory will reveal hypocalcemia with increased PTH. So because in the serum there will be low calcium, therefore the parathyroid glands will be activated or stimulated to produce more PTAH. That's why PTH will continue to be higher while the calcium will continue to be low, because the organs such as the bone will not respond to the action of the PTAH. So bone resorption will not happen. Calcium reabsorption at the kidney level will not take place, and the calcium absorption at the level of the intestine will not take place. This is what it means end stage, not end stage, end organ resistance to PTAH. So there are some people who have a genetic problem in that. So inherited in a autosomal dominant way, which is associated also with short stature and short fourth and fifth digits. So bivuga ko bafite icyo kibazo inherited from their parents. So I think this diagram is just mentioning the issue. So we have a parathyroid glands. So when there is low calcium, what happens? The PTH should be increased. But here now the issue is that this PTAH maybe is not increased. In that case, there will be, so this will be a primary hypoparathyroidism, if you can say so, because the issue is within the parathyroid gland itself. And if parathyroid parathormone is produced, but the organs which should respond to that hormone are not responsive, as the kidney, so the reabsorption doesn't take place at the kidney level, or absorption in the intestine doesn't take place, or the resorption from the bone doesn't take place, then this will be pseudo hypoparathyroidism. Questions about on the parathyroid glands?
No question.
Okay, so we proceed with the endocrine pancreas. So the exocrine pancreas, we covered it in GIT. So as you know, in the pancreas, we have mainly the exocrine pancreas. So it excludes enzymes that you know their functions. But within the pancreas, there are small islands, or here they're called the islets of endocrine cells. So usually a single islet consists of multiple cell types. So ntabwo usanga muri islet imwe harimo wenda cell zikora insulin cyangwa zikora glucagon, ahubwo usanga zose zivanze. So in one islet there are multiple types of epithelial of endocrine cells. So as you know, beta cells, they produce insulin, while glucagon is produced by alpha cells. We have also delta cells and so on. So there's another diagram talking about them. So here we have, now diseases here. The first slide was just to show things, the normal histology, the normal physiology. So 1 second, I must close the windows. It is raining here. Okay, so one of the most common diseases related to the endocrine pancreas is diabetes mellitus. Ngira ngo ahangaha murumva neza difference. There is no ntaho diabetes insipidus ya yindi iterwa n'ikibazo cy'amazi gusa, regulation of the water, ntawe ihuriye na diabetes mellitus, ari no yitwa diabetes gusa. Iyo bavuze diabetes nta kindi wongeyeho, you should understand it is diabetes mellitus they are referring to. So iyijyana n'isukari. So mu kinyarwanda bavuga ngo ndwaye igisukari, ni abashaka kuvuga ko arwaye diabetes mellitus. So the problem here is around insulin. Murabizi ko insulin akamaro kayo nako kugabanya isukari mu maraso, ahubwo isukari ikinjizwa muri cells aho igomba gukoreshwa. Glucagon is the opposite. Glucagon niyo it makes sure there is enough glucose within the serum. So ikikora cyane cyane ireba glycogenolysis, ni ukuvuga gufata glycogen ko isukari bikwa mu mubiri muri liver n'ahandi in the form of glycogen. So when glucose is needed, then glucagon igomba kujya kuri bya bigega ari byo glycogen ikayihinduzamo glucose. So now the issue here is the insulin. So we have then in healthy people, insulin will make sure the glucose enters inside the cell through insulin receptors. Now, iyo bavuze ngo unafite diabetes mellitus ya type 1, ikiba gihari ni iki? Ntabwo bafite enough insulin. So the pancreas doesn't produce enough insulin. Therefore, glucose hano ihita yiyongera mu maraso kubera ko insuline yari gutuma iyi glucose yinjira muri cells zikayikoresha, ntabwo ibihari. Niyo mpamvu umuntu azaba isukari nyinshi mu maraso, isukari nyinshi muri urine. Wenda niba mutanabizi, kera hatarabaho uburyo bwo gupima isukari kwa muganga, byabaga ngombwa ko abantu bakora kwa muganga bagutaga, they had to test the urine. Yakumva urine zirimo isukari nyinshi akamenya ko umuntu arwaye diabetes. So murumva it was dangerous kugira ngo abarwayi niba baje kwipimisha abarwayi bangahe bose bakekwaho diabete, bakabwira umuntu wenda uko muri lab cyangwa n'umuclinician bati nta yindi nyine, nta kindi urakora, urazinywaho wumve. It was dangerous. So medicine ntabwo nayo yavuye kure, ntabwo ari domaine zindi zonyine, nayo ni kure. So that is type 1 diabetes mellitus. Type 2 diabetes mellitus, insulin ibihari ihagije, ahubwo receptor to insulin nizo ziba zifite ikibazo. The cells fail to respond to insulin properly. So this is type 2 diabetes mellitus. So niyo uzajya usanga ikunda gufata abantu bakuze iyi ngiyi kubera ko bwa mbere abafite receptors zikora neza, ahubwo zikazaba damaged by some factors, as you know. So ikunda gufata abantu bakuze. Type 1 ifata n'abantu bakiri bato, n'abantu bakiri bato. Ikindi no kubavura, birumvikana kubavura iyi type 1 kuko icyabara insulin n'ubundi azavurwa na insulin. Type 2 insulin ishobora gukoreshwa ariko nta bigira akamaro kanini, ahubwo akoreshwa ubundi buryo bwabashisha glucose kwinjira muri cells. So niyo mpamvu imiti ya type 2 diabetes itandukanye n'iya type 1. Ariko rero nkuko muzabibona muri endocrinology, iyo umurwayi aje afite isukari nyinshi mu maraso, kuko utaramenya the patient is having, icyo ukora ni ukumugabanyiriza isukari, ukoresha insulin n'ubundi. Niyo uzabona umuntu bamuha insuline, bagende bagabanya dose bamuha, hanyuma nibagera inyuma babone burya wa muntu tumukuye kuri insulin tukamushyira ku binini byonyine byakora, aho nyuma nibwo nyine uza baza gufata icyemezo ati buriya ni type 2 diabetes mellitus. So nuko ko umurwayi aje bwa mbere, ntabwo ako kanya uhita umenya ngo type 1 or type 2. Icyo ukora ni uko ubona ko afite diabetes mellitus, then ibikurikira ni ukumuvura and other investigations, then ukazamenya type afite nyuma, none akazahabwa imiti iri specific afterwards. So insulin muzi ko iba ari inshinge, naho imiti batanga kuri type 2 akenshi ni ibinini. So Insulin deficiency leading to metabolic disorder characterized by hyperglycemia due to autoimmune destruction of beta cells. So type 1 ni beta ni autoimmune disease, aho beta cells which produce insulin have been damaged by T lymphocytes. So when you do a biopsy, you will find inflammation of the islets because of these T lymphocytes. They are the ones responsible for the inflammation. They will destroy the islets. So this is a genetic predisposition of this HLA, DR3 and DR4 and so on. Although antibodies against insulin are often present. So this is a sign of the damage that may be seen years before a clinical disease. So icyo bivuga ahangaha nuko ushobora gupima umuntu mbere ataragira clinical signs ukamenya ko yazagira type 1 diabetes mellitus. So when you see these antibodies, so ariko ntabwo ari ibintu bipimwa muri laboratoire izo ari zose, and I'm not sure if in our labs this is done. Otherwise, it may work as the screening test for type 1 diabetes mellitus. So what are the symptoms? So icyambere umuntu ufite diabetes azarangwa n'iki? Inzara nyinshi, akunda gusonza vuba, akunda kugira inyota vuba, akunda kwihagarika vuba. Ikindi akananuka. So when someone has the signs, ikintu cyambere uzareba ni diabetes mellitus type 1, even type 2 nayo sinye ni zimwe, ariko type 2 akenshi barabyibushye, n'abantu babyibushye mu gihe type 1 uyigize akenshi arananuka, diabetes ituma ananuka. So ngira ngo hari sinye rero zijya gusa n'ufite hyperthyroidism. Ibyo twabonye ufite za T3, T4 nyinshi, nawe hari sinye agera ahangaha, kurya cyane, kugira appetit, kurya cyane no kutabyibuha, ariko ntabwo agira too much urine nk'uko ahangaha muri diabetes bimeze. So ibindi bizari ngo complication, blood division. So hari ibyo bita diabetic retinopathy, ni icyo kibitera. So diabetes ubundi muri rusange yica gute? There is a damage of small arterioles, including arterioles within the retina and so on. Niza handi muri brain, mu mutima, coronary arteries and so on. They will be damaged. Akenshi ni icyo gituma bapfa. Hari n'abona bagenda bacaho amano, ikirenge, kubera iki? The vessels are damaged, the blood is no longer passing through there, and some parts of the body becomes ischemic. So again, I close all the windows. Okay, so ibindi ni intege nkeya, slow healing of the cats and swallows. So if igisebe kukivura, it is really very difficult. Ntabwo bikira kubera they are not well vascularized. You remember what we saw in healing and repair. For a wound to be healed, it must be well vascular. The oxygen must reach their nutrients and so on. So vaginal yeast infections, ibi ni ukuvuga iki? Na yeast abantu bazifite, ariko niba ziteye clinical signs and symptoms, ni ukuvuga ko zanesheje immunity. So diabetes mellitus, it is one of the diseases causing immunodeficiency. So otherwise, they have frequent urination, including frequent full diapers and so on. So ugasanga umwana buri kanya pampaze iruzuye, cyangwa se uburiri bwe buratose, mu kanya amuhindura akongera ari umwana. Umukuru we nyine ababibona ko ajya kwihagarika buri kanya. Ibyo ushobora kuvuga ngo ari kwihagarika buri kanya kubera ko yanyoye amazi menshi, kubera ko excessive hunger ituma n'ubundi anywa amazi cyane. Tunywa amazi cyane, ariko n'igihe uyu nguyu n'igihe atari kunywa amazi cyane, n'ubundi buri kanya bajya kwihagarika. So in childhood, the type 1, as I said, it manifests in childhood, while the type 2 manifests usually during adulthood. So there is features of insulin deficiency, high serum glucose, and we have explained this, weight loss, low muscle, and so on. So unopposed glucagon leads to glyconeogenesis. So glucagon yo irakomeza igakora izindi glucose ikuye muri glycogen, lead to glyconeogenesis, glucogenolysis, and lipolysis. You understand when there is lipolysis, hari consequences nuko umuntu azagira fatty acids nyinshi, while increased glycogenolysis also will exacerbate hyperglycemia. So ikintu cyo kuvuga ngo urine nyinshi, so symptoms nako amaterme zikoreshwa kwa muganga za nyazo ni polyuria, too much urine, polydipsia, kunywa cyane, glucosuria, this is glucose within the urine. Hyperglycemia exceeds renal ability to reabsorb glucose. Excess filtered glucose leads to osmotic diuresis and so on. So treatment will involve, of course, the lifelong insulin and kindi. Umuntu azaguma kuri insulin igihe kinini ufite type 1. So niba abandi kuva ari umwana aterwa inshinge, azatangira gukura bakamwigisha uko azajya azitera akaguma gutyo. Usually nta kintu kindi uba ushobora kumukorera. Ariko type 2 hari ubwo ahindura some behaviors, amubwira uhindura imirire, ujye ukora siporo n'ibindi bakagenda bagabanya n'imiti akazageraho abihagarika byose agakomeza. Ariko type 1 is very difficult. So ikintu rero kindi uretse za ischemic complications, ikindi kica aba barwayi ni acidosis. Ketoacidosis kubera twabonye ko hari umurwayi agira lipolysis, bituma agira free acids and so on. So at the end, increase the lipolysis leads to increase the free fatty acids. So, and you know that free fatty acids will be converted by the liver into ketone bodies. So when now someone has too much ketone bodies in the blood, it is when we say there is ketoacidosis, because it is are acids. As you see, there are acids. So the person will have what we call diabetic ketoacidosis. Abarwayi benshi babaza bari muri koma bafite diabete, akenshi koma bayitewe n'iyi ketoacidosis. So also they have a hyperglycemia, of course, hyperkalemia, metabolic acidosis because of these ketones, bagera guhumeka kwabo kuri hejuru vuba, dehydration, nausea, all this they are about ketoacidosis. Vomiting, mental status changes, fruity smelling breath, kubera iri acide usanga bafite ahumeka nk'umuntu ari imbuto cyane. Treatment is fluids, because to correct the dehydration, insulin and the replacement of electrolytes such as potassium, because they may use potassium in some cases. So ni muri rusange twaba kuri diabetes type 1. Indi kuri nababwira kugira ngo umurwayi atazagupfira afite diabete. Iyo wakiriye umurwayi ugakeka ko afite ari muri koma bazi ko arwara diabete, ikintu cya mbere umuha yari muri koma ari umurwayi usanzwe uzwi ko arwara diabete, ntabwo umuha insulin. Umuhaye ako kanya ahita, ahubwo yaje ari muri koma ikintu cya mbere umuha ni isukari. Why? It is because abarwayi benshi ba diabete ajya muri koma idatewe na hypercalcemia na hyperglycemia, ahubwo ari hypoglycemia. Kubera iki? Yenda yafashe imiti, yafashe insuline nyinshi, cyangwa yayifashe atariye, na glucose yari afite mu maraso itishiramo, so icyo gihe agahita ajya muri koma. So iyo rero ari muri koma ukamuha ka glucose gakeya, ukabona atangiye kuimprovinga uhita umenya ko yari hypoglycemia ariko umuteye insuline ahita apfa byo ni na glucose yari afite gace gahita gasha mu maraso ahita apfa ako kanya ariko iyo afite hypoglycemia ukamuha glucose nta kintu kinini bimuhindura so afite umuntu azwi ko arwara diabete aje ari muri koma uko butaramubaza icyano cya mbere ukora no kumuha glucose nkeya wabona habaye improvement ukamenya ko yari yagiye muri hypoglycemia wabona nta improvement hagati aho buri no gupima wohereje ibizami muri labo bakareba glycemia so akenshi nyuma y'iminota 50 cyangwa isaha bitewe na lab bahita bakubwira igisubizo afite isukari nyinshi none ukamenya ko umuha insuline so ntuzihute rero gutaha umuntu insuline agiye muri koma utaramenya neza ko afite hypoglycemia kuko azahita so muri magambo abiri hypoglycemia yica vuba hyperglycemia ntabwo yica vuba nicyo gituma dukoresha iyi approach so I hope that is well understood so umurwayi uzakuzaho rero nizere ko ntawe uzakugwaho kubera iyo mpamvu so type 2 diabetes mellitus this is as we saw on the diagram there is a resistance to insulin so because of that because the cells which would engulf if can say so or use glycogen they don't receive glucose they don't receive it because the receptors to insulin are not working so this is the most common type of diabetes mellitus especially in the United States and it affects 5 to 10% of the US population. And the incidence is rising. Kuko ijyana na lifestyle. Ijyana na lifestyle cyane cyane obesity, sedentarity, bya bintu bijya gusa n'ibya hypertension. So hano babihuriye cyangwa na cancer muri rusange. So it arises in middle-aged obesity. That's as I said. So it doesn't affect the small children. Children, they are affected by the type 1. So obesity will lead to decrease the number of insulin receptors. Whether they are destroyed by the fat itself, yeah, it is not clear. So there is a strong genetic predisposition. So uzasanga akenshi umuntu ufite diabetes 2 type 2 muri famille uzasanga ari undi muntu wayigize. Uzasanga undi wayigize. While for type 1 ntabwo ari kenshi ba genetic. So insulin levels are increased early in disease, but later insulin deficiency develops due to beta cell exhaustion. Histology reveal amyloid deposition in the islet. So bigitangira insulin iba ari nyinshi kuko insulin asanzwe bien sûr. Insulin irahari ahubwo receptor zayo nizo zidafite ikibazo. So kubera ko beta cells zijyaho zikananirwa zikaba exhausted zizajyaho zitagikora na insulin. Ni nko kuvuga ngo turariruye gusa ko dukora insulin bikanga umubiri ukagira ikibazo ubundi turariruye gusa. Okay, nirangaje nkoresha. Hanga mu byumve so zikaba exhausted zikarekeraho bigatuma at the end azaba abuze byombi insulin anabuze na receptors to insulin. So you understand that in that case then umurwayi ashobora guhabwa imiti itandukanye ni harimo imwe isa niyo muri type 1 diabetes mellitus. So the islets are destroyed and they are replaced by the amyloid, this pinkish material here. So clinical features also they are polyuria, polydipsia, and hyperglycemia. Type 1 bimeze, but the disease is often clinically silent. So akenshi bitangira silent nkuko babivuga ngira ngo akenshi signs ziza iyo yatangiye kugira na beta cell exhaustion. So na insulin ubwayo ikazamuka cyane nako ikagabanuka cyane mu maraso. So the diagnosis is made by measuring the glucose levels. This is the normal 70 to 100 milligram per deciliter of the serum. So ikindi gishoboka hari umurwayi aza kuko akenshi murabizi kugira ngo bayipime neza bapima umuntu atariye kubera ko iyo umuntu ariye mu byo ari habamo glucose bihita bituma muri blood iyo glucose yiyongera. Niyo mpamvu uzasanga bavuga ngo uheruka kurya igihe ki cyangwa se wihangane umare amasaha 6 nta kintu ufashe tubone ko gufata amaraso. So random glucose rero iyo irenze 200 ni ukuvuga umuntu ashobora kuba yariye ukamupima irenze 200 nibyo kiba ari ikibazo. Otherwise kurenga 120 si ikibazo mu gihe yari. So fasting glucose rero nicyo kibazo. Ibaye ari nyinshi renga 126 nibwo bigaragara ko ari ikibazo. So there is a glucose tolerance test with a serum glucose level more than 200 2 hours after glucose loading and so on. So the primary clinics. So the treatment here involves weight loss. As I said, this the type 2 diabetes mellitus is related to the lifestyle, obesity and so on. So weight loss through controlling the diet and doing exercises initially, but it may require drug therapy to counter insulin resistance. So uzasanga abafata sulfonyl ureas or metformin abanga barazifata kugira ngo ya resistance ihagarare cyangwa se receptors zongere zikore cyangwa umuntu agire receptors which can now allow the insulin to work. And sometimes, as I said, when the beta cells are exhausted, then you give insulin. So akenshi binabwo wenda upima beta cells ngo umenye ngo zaba exhausted kuko na biopsy of the pancreas is not easily done. Ahubwo ni ukuvuga ngo umuntu urabizi neza ko ari kuri type 2 diabetes mellitus umuhaye ibinini yanywaga ibinini noneho nyuma urabona ntacyo bimumariye so ukongeraho insulin none icyo gihe nibwo ubutekereje ko nubona bazongeye uzamenye ko ubwo baketse ko hari beta cell exhaustion. So they also have the risk of hyperosmolar coma, but which is not susceptible with ketotic acidosis. So high glucose, more than 500, leads to life-threatening this with hypertension and so patakazamara amazi menshi with hypertension and coma. Ketones are absent due to small amounts of saturating this acid. So there are some differences. Ariko nkuko mubibona type 2 isa naho iri mild as compared to the type 1. So type 1 is more severe. So the long-term consequences of diabetes in general. Okay, navuze yuvuze diabetes ushaka kuvuga diabetes mellitus. So type 1 and 2 both combined. So icyambere nuko bagira ibyago byinshi byo kugira stroke, kugira hypertension, pancreas malfunction, fatigue, risk of heart disease, of course, coronary disease, atherosclerosis. You know, atherosclerosis among its risk factors we have diabetes mellitus. So risk of infection, kweri kikaba ataka immunity ye ijya hasi, cataract and glaucoma, gastroparesis, and paralysis of the of the stomach, akarya biryo ntibigende and so on. Protein in the urine, this is proteinuria, nephrotic syndrome, ketoacidosis, dry cracked skin, nerve damage, foot problems. Niyo navuga kare bakunda kugira ikibazo cya vascularization, ischemia, sometimes with infection, abakagira gangrene. Usanga ari umuntu baciyeho ino, ahacira igihe ukabona baciye irindi, ikirenge bakagica, and so on. So there are many issues here. So the non-enzymatic glycosylation of vascular basement membrane, so non-enzymatic glycosylation of the vascular basement membrane. Yangu iki nicyo gitera za lesions twavuga kuri small vessels, especially the arteriole. So it affects large and medium-sized vessels, which leads to atherosclerosis. When it affects smaller vessels, it will be arteriolosclerosis. Cardiovascular disease is the leading cause of death among the diabetics, as I have said, and the peripheral vascular disease leads to non-traumatic amputations. So, in small vessels like this one, you will have hyaline arteriolosclerosis. This is an artery here, and it has a deposit, ibintu bitukura byajemo kuri tunica media aho ngaho. So, preferential involvement of efferent arterioles lead to the glomerular hyperfiltration injury. Kugira ngo murabyibuka nga twabibonye kuri kidney. Efferent arteriole niyo ifatwa ni ukuba yayindi isohora ijyana amaraso amaze kuba filtered. Iyazana kuri glomerulus niyo afferent. So, ikibazo hano diabetes ifata efferent, bivuga ko amaraso araza muri afferent kuko imeze neza ari menshi agakomeza akaba filtered, then yamara kuba filtered akabura aho asohokera. Niho twabonye iki cyitwa hyperfiltration injury. So remember that. And usually there will be microalbuminuria, meaning they lose their albumin within the urine, ariko habanza kugenda duke duke harimo ijambo micro. So eventually azatakaza albumin nyinshi none hagire overt nephrotic syndrome. So and when you look at in the biopsies, they will have the chimeric stereo Wilson nodules in the glomerulus. Non-enzymatic glycosylation of the hemoglobin produces glucated hemoglobin, a marker of glycemic control. So this is very important. Kubera ko yakakano baragapima mu marabu menshi kubita. Kubera iki? Iyo wakiriye umuntu ukabona afite glucose nyinshi mu maraso, you are not sure niba atari ikintu kije ako kanya wenda yanyoye ibintu birimo isukari nyinshi cyangwa yabinyoye ejo cyangwa inzoga. So kugira ngo bamenye ngo ni ikibazo amaranye igihe, donc biga ko ari diabetes, bakora iki ngiki baba hemoglobin glycate cyangwa glucated hemoglobin. So iyo bapimye rero bagasanga iri hejuru, it is a sign that this person has been having a high hyperglycemia for a long time. So in that case, it will be just easy to confirm this is diabetes mellitus. Igisiga kikaza kumenya ngo ni type 1 or type 2. So muzabona muri teaching hospitals bavuga ngo dusabe hemoglobin glycate ni ikibazo abasha. So other consequences are osmotic damage. So glucose freely enters into Schwann cells. You remember the Schwann cells and nizazi zikora myelin sheath around the neurons in the peripheral nervous system, while in the central nervous system, the counterpart of Schwann cells are called how do you call them? So it's not oligodendrocyte. Yes, oligodendrocyte. So the glucose freely enters into Schwann cells around the nerves. Pericytes, you know, they are around the blood vessels, just behind so we have around the endothelial cells of the vessels, and then the retinal blood vessels and the veins. So this glucose enters there freely. When someone is diabetic. Too much glucose itera ibibazo byinshi mu maso n'ahandi no nerves. This is the limit. Now, but how comes the injury? When the glucose ubwayo ntihita itera injury, how does the injury happen? So normally we have a hormone called the aldose reductase, which will convert glucose to sorbitol, resulting in osmotic damage. So this is presented there. So we have a glucose which entered there. Then the enzyme aldose reductase is there, and it will convert the glucose into sorbitol. So sorbitol ubundi yagombye guhita ihindurwa nayo muri fructose. Ni enzyme yitwa sorbitol dehydrogenase. Ariko then niba glucose ari nyinshi cyane, Aldose reductase yo ikaba ari nyinshi izahita ihindura muri sorbitol, ariko sorbitol dehydrogenase usually ntabwo iba ari nyinshi, bityo sorbitol nkeya n'izahindurwamo fructose, otherwise sorbitol izaba ari nyinshi itere osmotic damage. So nicyo gisobanuro cya damage ziva kuri nerves, the small vessels in the retinal lens and so on. So and then the patient azagira peripheral neuropathy because of this neuron which are affected. You have impotence because of vessels maybe in the genital system are affected. Blindness, you can understand because the retina and the lens, and the cataract especially refers to the lens, while blindness can be lens or retina. So diabetes is the leading cause of blindness in the developed world, so in Western countries. So apart from that, from diabetes, now we go to the tumors which affect endocrine pancreas. So as we said, we have many types of cells in the islets. Alpha cell produce glucagon, beta cell produce insulin, delta they produce somatostatin. If I remember well, yango twabiga muri secondaire, iyi ntabwo ari hormone ya mbere discovered. Probably is the one. I don't remember what, but this is among the first hormones which we have discovered. So D produces gastrin. So therefore, the tumor which arises from alpha cells, because it makes glucagon, the tumor will be called glucagonoma. And murabyumva kubera glucagon nyinshi iri gukorwa hazahora hariho isukari nyinshi mu maraso, because glucagon ikikwa no kongera glucose mu maraso. So uwo muntu arashobora kugira arangwa no kugira diabetes, dermatitis and so on. Insulin, too much insulin azagira no, the cells, if the tumor involves the cells producing insulin, the tumor will be called insulinoma, and as a consequence, this person will have hypoglycemia because insulin makes sure that it decreases the glucose within the serum. Somatostatin, the tumor will be called somatostatinoma. Usually this they can present with the mild diabetes. Gastrin, they have a gastrinoma. So gastrin ni hormone ni ituma umubiri ukora acide nyinshi, acide yo mu gifu. Gastric acid, ari hydrogen chloride. Niyo mpamvu umuntu ufite gastrinoma agira ibisebe byo muri mu gifu no muri duodenum because of too much acid production. So then the islet says from A to D, also they produce, all of them, vasoactive intestinal peptide. Ni ukuvuga ntabwo ikorwa n'imwe muri aya masaha ahubwo ni zose zishobora kuyikora. So this they will have this watery diarrhea, hypokalemia, and acroridria, and so on. So serotonin, usually this is produced by tumors we call carcinoid tumors or neuroendocrine tumors. STH, they can also produce STH, and then we will have Cushing disease or Cushing syndrome. Adrenal glands. So okay, I don't remember the long name of MSH with melatonin and so on. Melatonin, so they have hyperpigmentation. So these are the islets. So interacinous cells, it means these are cells which are neuroendocrine, ntabwo ziri muri islets, ziri hagati muri za sina hamwe muri exocrine pancreas, ariko izi selile ubwazo zo ni endocrine, nuko zitari muri islets. So I have a cell, cells F, which produce a pancreatic polypeptide, and then here, when there is a tumor from these cells, they will produce multiple hormonal syndromes. And then we have this EC type of cell. So it will produce, you see that it has something to do with serotonin. So also it is seen in carcinoid tumors. So the tumors of the endocrine pancreas account for less than 5% of all pancreatic neoplasm. So usually the tumors of pancreas, they are from exocrine pancreas, not from the endocrine one. And this can be component of many multiple endocrine neoplasm, as we saw. What I want in the thyroid. So sometimes we parathyroid hyperplasia and the pituitary adenomas. So insulinomas present as episodic hyperglycemia with mental status problem, and so on. So when you give them glucose, their clinical condition improves. So insulinoma can be diagnosed with decreased serum glucose, increased insulin, and so on. So gastrinoma, so we are just talking about these tumors we saw here. After insulinoma, gastrinoma are present as treatment-resistant peptic ulcers. Kwa kwikora gastrin indituma habaho too much gastric acid production. So uyu muntu rero azabagira iyo ulcers, mukomeze mumvure nimuvura bigiye kugira icyo bitanga. Why? Because there is a mass. Usually kaba ari akantu gato utanakabona kuri endoscopy. Yes. So kabitera. So somatostatinoma present as acroridria. So there is no production of the hydrogen chloride acid. Icyo mwabona hanga nuko gastrinoma, gastrin, akazi ka gastrin gatandukanye cyangwa se kari opposed n'akazi ka somatostatin. Somatostatin, it decreases or inhibits the production of acid, or it is antagonistic to the gastrin. So, and they will have cholelithiasis with steatoria due to inhibition of cholecystokinin. So VIPoma, so VI, you remember here, it is about the vasoactive intestinal peptide. So secrete excessive vasoactive intestinal peptide leading to watery diarrhea, hypokalemia, and acroridria. So this diagram is explaining what you saw on the previous diagram at the table. So as I said, in the pancreas, we have exocrine pancreas. You see the ducts and the lobules, but you have islets. So in each islet, you have a different types of cells. So ntabwo islet imwe bikora insulin ngo indi islet ikore glucagon, no. In one islet, you have a different types of endocrine cell. So any question about endocrine pancreas? Okay, so we proceed with adrenal cortex. So the adrenal cortex, you know, adrenal gland is having a cortex and a medulla. So we start with cortex, then we will proceed with the medulla itself. So, muri histology, the cortex has 3 layers. Have a glomerulosa, fasciculata, and reticularis. Niko zikurikirana ibanza on peripheries glomerulosa. It produces mineralocorticoids, especially aldosterone. The fasciculata produces glucocorticoids, such as cortisol, while the reticularis will produce androgens, such as dihydroandrogen and so on. So harimo na za testosterone. Of course, nimo ziza na za progesterone and so on. So cortical hormones are derived from cholesterol. So cortical hormones, is also muri adrenal cortex. They are derived from cholesterol. Cholesterol again, transform. So sequential enzymatic modification produces either mineralocorticoids or glucocorticoids or the androgen. So all of these, they are coming from the same. So if you see on this figure, you see cholesterol, when there is an enzyme desmosterase, then you have pregnenolone, then you have here an enzyme which will cause this to produce 17 oxalate pregnenolone, and then this from this we'll have this androgen dione and so on. And then from here, if we went straight forward to progesterone, then this can be modified until we have also androstenedione. So it means you can have testosterone just from the progesterone. So if this other enzyme is added from progesterone, we have deoxycorticosterone. And you understand that from this, it will be easy to get cortisol. And then if you continue this way, you will arrive to aldosterone. So you find that all these enzymes, not enzymes, these hormones, aldosterone, cortisols, androgens, they are derived from the cholesterol itself. Wenda bishobora no gusobanura impamvu bavuga abantu bari obese, nko ku bagabo obesity ishobora kuba kimwe mu bikurura prostate cancer. Ni ukubera ko prostate cancer twabonye ko ikorwa, ko iterwa, bimwe mu bitera ni ukuba umuntu afite testosterone nyinshi, kandi testosterone hano murabona bimwe mu biturukaho harimo cholesterol. So each layer secretes distinct hormones based on enzymes present in that layer. Okay, so murabyumva, ni ukuvuga cholesterol niba yibere muri glomerulosa izakora aldosterone. Niba cholesterol iba muri fasciculata izakora cortisol bitewe na enzyme zihari. Si ukubera amaseri ari ahubwo ni ukubera enzyme ziri hari. So that is the beginning of this last sentence. So the first disease you can see here is the hyperaldosteronism, meaning that there is excess aldosterone. As we saw here, aldosterone is produced in the glomerulosa, and it is a type of mineralocorticoids. Ikindi bisobanura nuko hano this aldosterone, as we also know through physiology, it regulates the metabolism of minerals, where cortisol can regulate the metabolism of the glucose or other carbohydrates. So classically presents as hypertension, hypokalemia, and metabolic alkalosis. So the explanation is here: aldosterone increases absorption of sodium and the excretion of the potassium and the hydrogen ions in distal tubules and collecting ducts. So that is the explanation of this metabolic alkalosis. Kubera ko umuntu aba atakaje hydrogen ions arizo muzi zituma umuntu agira acid. So kuba yatakaje nyinshi biba bituma ahantu hahinduka alkalinized, because everything which is related to acid was lost. So primary hyperaldosteronism is most commonly due to bilateral adrenal hyperplasia. So biranumvikana niba adrenal gland yongereye ubunini izakora hormone nyinshi, muri zo ishobora kuba aldosterone cyangwa ikaba cortisol cyangwa se ikaba androgen. So or adrenal adenoma or adrenal carcinoma in some cases. So adrenal adenoma, so data Cushing syndrome. So in this figure you can find the mass here. So hano hari hyperplasia, so it means the whole adrenal gland is just increasing in size because of the increase in the number of cells. But in adenoma, there is a circumscribed tumor affecting one part of the gland itself. So the treatment is shown here. So the secondary hyperaldosteronism arises with the activation of the renin-angiotensin system. that we saw in physiology, renovascular hypertension or chronic heart failure and so on. Not chronic, congestive heart failure. So primary and secondary hyperaldosteronism are distinguished by plasma renin and edema. How? So ibi ni ukuvuga as a clinician ni cyiza ko afite primary disease or secondary one. So in primary hyperaldosteronism, we have decreased renin and no edema because they call it aldosterone escape. In a secondary one, there is increased renin and also there is edema. So if here we have edema and increased renin, while in primary there is no edema and there is a decrease in the renin. And of course, no prima aldosterone ahombi is very heavy. Consider how is it hyperaldosteronism. So glucocorticoid remediable aldosteronism leads to familial and so on. So there is aberrant expression of aldosterone centers in the fasciculata due to genetic mutation through an autosomal dominant way. So they present as they are children with hypertension and hypokalemia, and the aldosterone is high, while the renin is low. So it's low. So it means laboratory findings, they will show features of primary hyperaldosteronism, but you will see if there is edema or not. These ones, they respond to the dexamethasone, so you need to correct that technique. The diagram here is showing the issues around the aldosterone. So aldosterone, here we have a glomerulosa, fasciculata, reticularis layers of the adrenal gland. Then in primary hyperaldosteronism, we have high aldosterone and low renin. In secondary, we have high renin and high aldosterone, as we saw. Hanga tukabonye ko edema exists in secondary. In secondary hyperaldosteronism. So the causes, the most common causes of primary hyperaldosteronism, we have coronary disease, we have adrenal hyperplasia, we have adrenal tumors, as we saw, congenital adrenal, and so on. This one will come back on congenital adrenal hyperplasia. So the diagnosis modalities are shown here and the treatment. So then we have a syndrome called the Lido syndrome, which mimics hyperaldosteronism. So here we have a decreased degradation of the sodium channels in connecting tubules due to genetic mutation. And this is in autosomal dominant way. So the disease affects the children. They develop hypertension, hypokalemia, and the metabolic alkalosis. They have low aldosterone and low renin. Low aldosterone and low renin. So muri rusange nubwo afite ibimenyetso bya hyperaldosteronism, ntabwo bigaragaye impamvu kubera ko the child has low aldosterone. So the diagnosis by genetic testing, which usually we don't do, as I said. So the syndrome of apparent mineralocorticoid excess or SAME, also it mimics sometimes hyperaldosteronism clinically. So there is a deficiency in this enzyme, hydroxysteroid dehydrogenase 2. And this will allow the cortisol to activate renal aldosterone receptors, and this is transmitted or inherited in an autosomal recessive way. So ni ukuvuga ko ahangaha ikibazo gihari, cortisol yo izakora activation of the aldosterone receptor. Ni nkaho zizabeshwa ko ari aldosterone ihari kandi atari ahubwo hari cortisol. Ni hamwe twabonye kuri Graves disease in the thyroid. So again, this presents within childhood, with hypertension, hypokalemia, and metabolic alkalosis, but with low aldosterone and low renin. So you understand that the signs here, they are almost the same as in this case here. So this is diagnosed by raw urine-free cortisone and genetic testing. So this diagram is showing that cortisol ihindukamo cortisone bitewe n'izi enzyme and vice versa. So excess cortisol, it is called hypercortisolism cyangwa se Cushing syndrome. Twagiye tubivugaho kenshi. Cushing syndrome ni uko umuntu afite cortisol nyinshi, ntabwo ari aldosterone uko twabonye ibyayo. So clinical features, as after muscle weakness, with thin extremities. Urabona utuboko twe n'utuguru twe turananutse kubera muscles, they are weak or wasted. Ariko ahandi inda irabyibushye, ibitugu birabyibushye, akagira fat pad ameze nka buffalo. Maybe bifite umugongo bwite. So it is what to say. So we can say there is a central obesity. Periphery is not obese. So obesity ikunda no kuri trunk. So the cortisol will break down the muscle to produce amino acids for glyconeogenesis. Bishobora no kuba ko ashobora no kugira signs of diabetes. So they have moon faces, buffalo hump, and truncal obesity. So high insulin due to high glucose increases storage of fat central. This is how barasobanura impamvu umuntu afite fat ahangaha hagati. Ni ukubera ko aba bantu bagira insulin nyinshi. Iyi insulin nyinshi abunda akazi kayo nako icyambere igabanya isukari mu maraso, ikindi gatuma fat iba stored around in the centroid, the trunk, abdominal cavity, trunk, and the back. They have abdominal striae. Impaired collagen synthesis results in skin thinning. You see the streaks here. So hypertension, often with hypokalemia and metabolic alkalosis, high cortisol increases the sensitivity of peripheral vessels to catecholamine. So sensitivity ni ukuvuga catecholamine nubwo zitaba ziyongereye, peripheral vessels zizifata nk'aho hari catecholamine nyinshi. When we say catecholamine ni adrenaline and noradrenaline, which they increase the blood pressure. So at very high levels, cortisol will cross-react with mineralocorticoid receptors, although here or aldosterone will not be increased, but the body will behave as if there is too much aldosterone. So other things here, there are osteoporosis. So hiyongereyeho za parathormone. So and there is immunosuppression. So diagnosis is based on a 24-hour urine cortisol level. So ntabwo bizabihagiye kuba ngo mufate umuntu urine mupime, ahubwo bizasaba gufata 24-hour urine. So niba ari umurwayi utarembye utarewe mu bitaro, ushobora kumubwira akagira ikintu urine zose azazishyiramo akaziza. Otherwise, better maybe to keep the patient at the healthcare facility just to monitor everything. So they have a late night salivary cortisol level. Muziko ibinyago murabizi hari hormone zimwe na zimwe zikorwa bitewe n'amasaha, hari zikorwa So someone has removed me from the platform. I don't know why. So we're explaining the issues of this cortisol 24 hours. So plasma STH distinguishes STH-dependent causes of Cushing syndrome from the STH-independent causes. So we have a table here to read, but you can understand that the cortisol kuba yiyongereye maso bishobora guterwa na STH because it is the one responsible for that. It can be responsible for overproduction of cortisol nk'uko bikora kuri aldosterone. So if ACTH independent, next step is to look for an adrenal lesion. Is a CT scan, to do CT scan to look for any adrenal lesion. If it is dependent on STH, next step is high dose dexamethasone test to see if it responds to that. So high dose dexamethasone test is done by usually when it is positive. This high dose dexamethasone will suppress ACTH production by a pituitary adenoma, and so serum cortisol is lowered but does not suppress it to PS. So these are text to read. So this is the table showing the just the cause of Cushing syndrome. Have exogenous glucocorticoids, most common iatrogenic cause. So iatrogenic means something caused by healthcare system. Okay, so usually in this case there is low ACTH. So high dose dexamethasone will have nothing to do here. Imaging will show no tumor. Treatment is tapering of steroids if possible. So if the cause of Cushing syndrome is the SCTH secreting pituitary adenoma, and you see that this is the most frequent reason for Cushing syndrome. So STH will be usually increased. Ikorerwa muri pituitary gland. Then high dose dexamethasone will suppress STH production. High dose dexamethasone test, which would be done. So imaging will show pituitary adenoma, and the treatment in near resection is twabonye kare transsphenoidal resection of the pituitary adenoma. If there is ectopic STH secretion, ishobora gukorwa nko muri lung tumors cyangwa paraneoplastic syndrome twavugaga. Of course, the STH will be high, but also there will be androgen excess and the hyperpigmentation. So if you do high dose dexamethasone, it will not, there will be no suppression of STH production. And imaging can reveal the ectopic source of the STH, for example, the lung tumor, as we said, a small cell carcinoma or carcinoid tumors of the lung or elsewhere. So, and then you will have to resect that tumor surgically. Primary adrenal adenoma, meaning that the issue is that the adrenal gland itself or hyperplasia or carcinoma, usually STH will not be high. It will be instead low because of the feedback, negative feedback mechanism. Homo uzabona ko hakozwe cortisol nyinshi, then usabe ko STH igabanywa. So the high dose dexamethasone test will have nothing to do here. Imaging can show that the adrenal gland is either hyperplastic or having a tumor, which should be resected. So another condition, as I said, we should see here is the congenital adrenal hyperplasia. Congenital adrenal hyperplasia. So you can understand there is a hyperplasia for the adrenal gland, which is congenital. Someone was born with this. So it is the inherited disease. The transmission is autosomal recessive. So it is due to enzymatic defect in cortisol production. Therefore, kubera ko hari cortisol ikorwa na adrenal gland ari nkeya, bizatuma habaho feedback mechanism izasaba ko pituitary gland izakora STH nyinshi ngo wenda zistimule adrenal gland ikore noneho cortisol nyinshi. Mu kuyistimira ni nka bya bindi twabonye kuri thyroid, then hazabaho hyperplasia of the cells of the adrenal gland. Nkuko ahandi twabonye iyo hatari T3 T4 zihagije, TSH izasaba thyroid kuba nini, kuba hyperplastic. So mineralocorticoids and androgens may be increased or decreased depending on the enzyme defect which is there. So if there is a 21 hydroxylase deficiency, which is the most common cause in 90% of the cases, aldosterone and cortisol will be decreased. Steroidogenesis will be shunted towards androgens. And the classic form present with in neonates, of course, is congenital. Umwana akivuka uzahita agaragaza ibimenyetso hyponatremia, hyperkalemia, and life of training hypotension. Salt wasting type. Salt wasting, salt ni ukubera ko azaba afite sodium nkeya, niyo mpamvu wasting nta biro azaba afite. So females have clitoral enlargement, or clitoris is very much enlarged, and sometimes you can think it is a penis. That's why here it is written there is a genital ambiguity. So because it is a neonate, they will not be sure if this is a male or a baby boy or a baby girl. Non-classic form presents later in life with androgen excess leading to precocious puberty in males, or hirsutism with menstrual irregularities in females. So I think the diagram is explaining the same. The classic congenital adrenal hyperplasia. Here, so there will be excess STH release, which, as I said, will stimulate the diffuse enlargement of the adrenal gland. Ibyo byose byatewe n'iki? Byatewe nuko wenda umubiri ubona nta cortisol ihagije ihari, then STH igahita iba nyinshi kugira ngo adrenal gland ibe nini ikore cortisol ihagije, and so on. So I think this clitoris enlargement, we saw the deoxycorticosterone leads to hypertension and so on. So newborn screening for congenital adrenal hyperplasia, you understand, you can screen by investigating the 17-hydroxyprogesterone. This test should be routine. Ariko ko nabivuze muri our settings, because we do not do genetic testing regularly or just as a routine. So this does not apply to our system. So the treatment for this is to give glucocorticoids. Mineralocorticoids also may be given, but this depends on the reason, on the problem which is there. So adrenal insufficiency also can happen, and this diagnosis is made when there is a deficiency in adrenal hormones, not only one hormone, but all of them. So it will mean that the whole adrenal gland is defective, no longer working. So acute insufficiency presents as weakness and shock, and the causes include abrupt withdrawal of glucocorticoids. When umuntu wamuvuraga umuha glucocorticoids zistimula adrenal gland, then ugahita ubihagarika. So there is treatment of Cushing syndrome. Cushing syndrome ubwayo ni nkaho umuntu afite hyper adrenalism, if that term can exist. So adrenal gland is overworking. So mu kuyivura rero ugerageza kugabanya akazi gakorwa na adrenal gland. Ibyo rero bishobora gutuma ushobora kumuha imiti myinshi bigatuma noneho adrenal gland yose iba silenced. So Waterhouse-Friedrich syndrome characterized by hemorrhagic necrosis of the adrenal gland. So whatever can cause necrosis of the adrenal gland, you understand it will cause, it will lead to adrenal insufficiency. So they have sepsis and DIC, disseminated intravascular coagulopathies in young children, especially they develop an infection by Neisseria meningitis. So the chronic insufficiency aortic Addison disease present with progressive symptoms such as hypotension, weakness, fatigue, nausea, vomiting, and weight loss. So Addison disease no kuvuga ko n'umuntu ntabwo afite. So the adrenal gland are not working, and in a chronic way. With the Cushing syndrome, it is opposite. So the adrenal insufficiency, the most common reason is the Addison disease. So and you have here the findings, clinical, lab, and so on. So Addison disease most often arises with progressive adrenal damage. Common causes include autoimmune destruction. And this is the most common cause in the Western countries. Another cause is TB, tuberculosis, which can affect the adrenal glands, or if there is a metastatic carcinoma, which comes to destroy the adrenal glands. So autoimmune adrenalitis can be a component of autoimmune polyendocrine syndrome. So no kuvuga hari abantu bagira autoimmune disease by which all their endocrine organs can be affected or attacked by autoantibodies. So Addison disease may also arise with pituitary or hypothalamic disease. So niba ikibazo cya Addison disease giterwa na adrenal kiva muri adrenal gland itself bayita primary disease. Niba cyatutse muri pituitary gland ni secondary, niba cyavuye muri hypothalamus ni tertiary Addison disease. So that is the difference between these. So there will be hyperpigmentation because of high STH and hyperkalemia because of low aldosterone, which suggests primary adrenal insufficiency. Tertiary and secondary insufficiency has no hyperpigmentation. Kubera ko ubwayo STH ihari. STH ikorerwa muri pituitary. So niba iri hasi cyane uko pituitary or the hypothalamus zitari gukora akazi kazo. The lack of STH response with methyl-rapone stimulation test supports a secondary or tertiary cause. Kugira ngo ibi twakunze kubivugaho stimulation cyangwa se response twabibonye kuri glucose intolerance cyangwa tolerance, twabonye kuri dexamethasone, none aha tubonye methyl-rapone nayo ituma bamenya ko umuntu areponda STH izamuka cyangwa se ikagabanuka bitewe bamuhaye umuti, bitewe nuko yareponze cyangwa it doesn't respond, then you can know the issue is from the adrenal gland itself or it is from the above, meaning the pituitary gland and the hypothalamus. So STH response with CRH stimulation test suggests hypothalamic or tertiary disease. So this is corticotropin release hormone. So treatment is again glucocorticoids and the mineralocorticoids. And I think this was also the same for the previous disease. So then we end with adrenomedulla. So the adrenomedulla makes two main types of hormone. These are catecholamines. Epinephrine, ari naho mwita adrenaline, hakaba na norepinephrine, ari naho yitwa noradrenaline. So indi ikorerwa hariya ni dopamine, ariko ivurwa hano cyane ni adrenaline na noradrenaline, that we know very well in physiology. Ikindi twavuze nuko iyo ufite nk'umuntu yagize ari muri shock, imwe mu miti harimo adrenaline kubera ko it causes, because in shock haba harimo vasodilation. Iyo umuhaye umuti umutera vasoconstriction, nibura vessels zikongera zikaba patent ku buryo n'amaraso yazinyuramo akagenda. Ikindi nuko adrenaline ituma n'umutima wongera kugira imbaraga iyo wahagaze. So muzabona n'umuntu agize ikibazo akagwa akagira collapse, umutima ugahita uhagarara, mu muti wa urgence bahita bamuha ni adrenaline. So these are sometimes called stress hormones. So they are hormones which are produced in stress usually. Uretse iyo miti navuga iyo baha umuntu nk'imiti ariko umubiri wacu urazikora. Ariyo mpamvu usanga kugira ngo hari benshi babivuga bati na kurya inyama z'itungo ryishwe nabi ribabajwe cyane, iyo yishwe iba iri tortured izaba yakoze izi za adrenaline nyinshi, bityo kurya inyama zayo cyangwa se hari y'amaraso y'amatungo bya-expose umuntu kugira izo catecholamines. So there are people who say so, especially those who advocate not eating meat. So adrenal glands secrete hormones which regulate stress and the metabolism and supplement other glands. So hano cyo bivugira nuko nka adrenal gland ikora hormones zikorwa na testes, ikora testosterone, igakora estrogen, igakora progesterone, ku buryo ngo twabivuzeho kuri prostate gukura testis mu muntu kumuvura prostate cancer ni ikintu bigabanya koko testosterone, but it is not completely absent testosterone because there will be another testosterone produced by adrenal glands. So the diagram is again showing the layers of the adrenal glands. We have the cortex, in which we have zona glomerulosa, zona fasciculata, and zona reticularis. Then you have a medulla producing adrenaline and noradrenaline, which stimulates the sympathetic autonomous nervous system. So the tumors which affect the medulla, the most frequent one is pheochromocytoma. So it is a tumor usually considered as malignant, nubwo ari usanga selile zitari malignant, ariko rero ikibazo cyawe ni kimwe. So igihe cyose uzakeka ko umurwayi afite pheochromocytoma, ikintu cya mbere uzirinda ni ukumanipira iyo tumor, because as you touch it, za hormones zitangira kuba nyinshi, ziba released cyane, zikava muri tumor zikinjira mu maraso, ugasanga umuntu agize as a storm of adrenaline or noradrenaline. So nk'iyo bagiye kubaga umuntu ufite pheochromocytoma babizi babyita hari procedures bakurikira. Iyo batabizi rero umurwayi ntabwo ashobora kuva kuri table bamubagiraga, kubera ko adrenaline zisohoka ari nyinshi cyane ahita apfira hano. So iyo babizi rero ko ari pheochromocytoma bagenza bate, babanza gufunga vessels ziva aho ngaho aho tumiri zigarura amaraso muri central system, babanza kuzifunga burundu kugira ngo adrenaline zitaza kujyamo zikaza ku mutima ziri umubiri wose umurwayi akabapfira. So nicyo bakora, nicyo gikorwa ahangaha. So that's why I say this tumor is dangerous because of this catecholamines that it makes. So urabona itera hypertension, headaches, palpitation, tachycardia. Iyo bizamutse cyane tachycardia no kuvuga bihinduka fibrillation, cardiac fibrillation or ventricular fibrillation, handi umutima ugagara kubera gutera vuba vuba ugeraho ugahagarara. Then fibrillation usually leads to death. I think we saw it when we are dealing with the cardiac pathology. So otherwise, it is having cells which are chromaffin. Chromaffin hari inzo twita chromophobe. So chromaffin, when you stain it, the cells become pink or blue like this. Chromophobe, muzi ko ari ikintu kidakunda fin, there is a fin tension. So chromophobe, they don't take a pigment. So therefore, when you stain, they become whitish. Nkuko hari ahantu hamwe hari whitish. So this tumor is a chromaffin, is not chromophobe. So the treatment is adrenalectomy. Catecholamines may leak into the bloodstream upon manipulation. So this is what I was explaining. So That's why before doing surgery on a pheochromocytoma, they administer these drugs. Irreversible alpha blocker followed by beta blocker. These must be administered. Indi methode bakoresha nka CHK niyo gufunga vessels zose ziva kuri adrenal gland kugira ngo adrenaline idatambuka ikajya guteza ibibazo. So often follows the rules of tens. So ibi ni bigufasha kumenya ibiranga pheochromocytoma. So it is bilateral in 10%, meaning that it affects both the left and the right adrenal gland in 10% for cases, 10% familial, 10% for the cases are familial syndromes, 10% of pheochromocytoma are malignant, and navuze ko zimwe ziba ziri overtly benign, others are malignant, and 10% are located outside of the adrenal medulla. Nuvuga ko ushobora gusanga pheochromocytoma itari muri medulla ahubwo yari muri cortex, rimwe na rimwe yaragiye n'ahandi, and bladder wall, mesenteric artery, and so on. So malignancy is defined by metastatic spread. The patients require long-term follow-up. And you remember that in the multiple endocrine neoplasia, 2A and 2B, we saw that pheochromocytoma is one of the features, as we saw. So I think this was the last slide. So thank you for the attention. If you have a questions, you can ask them.